Assalamu alaikum. Let's dive into pediatric hematology. Before jumping into that, look at this. Can you tell me the name of this sign? If you know, put it in the comment box. Okay, now, so neonatal polycythemia. Neonatal polycythemia is a very high yield topic. This is an emergency topic of pediatric hematology. In here, what is the main thing in neonatal polycythemia? In neonatal polycythemia, hematocrit count is more than 65%. If hematocrit count is more than 65% in term infant, so in term infant more than 65, it is neonatal polycythemia. There is increased erythropoiesis from the intrauterine hypoxia and maternal diabetes, hypertension, smoking, IUGR, and there may be erythrocyte transfusion, delayed or cord clamping, twin transfusion, and the most important, there are some genetic association 13, 20, 13, 18, 21. 13 is trisomy 13 is Patau, trisomy 18 is Edwards syndrome, and trisomy 21 is Down syndrome. The most important point is ruddy plethoric skin. In neonatal polycythemia, there is ruddy plethoric skin. There is hypoglycemia and hypocalcemia. Why hypoglycemia? Due to increased cellular uptake. Due to increased cellular uptake. And there is increased sign of blood viscosity, and which leads to respiratory distress, irritability, jitteriness, and lethargy. And there may be abdominal distension, IV fluid, glucose, partial exchange transfusion. IV fluid, glucose, and partial exchange transfusion should be done. IV fluid, glucose, and partial exchange transfusion for neonatal polycythemia. The third one, there, if there is polycythemia, the partial exchange transfusion should be done. Okay, now infantile vitamin K deficient bleeding. In infantile vitamin K deficient bleeding, we know that baby's gut is sterile, so there is low vitamin K store. As there is sterile gut and poor placental transfer and low content in the breast milk. In the breast milk, there is low content of vitamin K. So, and insufficient vitamin K used by the immature liver. Clinical feature classically present on day 2 to 7 days of life. Classically presence on 2 to 7 days of life. There is easy bruising, umbilical, mucosal, and GI bleeding, and there may be intracranial hemorrhage. Lab finding: PT is high, PTT is severe, PTT is higher, normal platelet count. PTT is higher and normal platelet count. Prevention: intramuscular vitamin K at birth. Late onset can occur up to age 6 months. The diagnosis is confirmed by reversal of lab abnormality after vitamin K administration. Afibrinogenemia is a rare autosomal recessive bleeding disorder. Afibrinogenemia is an autosomal recessive bleeding disorder characterized by absent fibrinogen production. In here, there is severe bleeding, classically develops at the side of the umbilical cord, after birth. PT, PTT, and thrombin time is prolonged. PT, PTT, and thrombin time is prolonged. Now, anemia of prematurity, AOP, anemia of prematurity. In anemia of prematurity, there is impaired erythropoietin production. There is impaired erythropoietin production, short RBC cell lifespan, and iatrogenic blood sampling. Impaired erythropoietin production, short RBC lifespan, and iatrogenic blood sampling. Clinical manifestation usually asymptomatic. There may be tachycardia, apnea, and poor weight gain, low hemoglobin and hematocrit, low reticulocyte count, low hemoglobin and hematocrit, low reticulocyte count, and there is normocytic, normochromic red blood cell. There is normocytic, normochromic red blood cell. Minimize blood draw, iron supplementation and transfusion. Minimize blood draw, iron supplementation and transfusion. Now, physiologic anemia of infancy. In physiologic anemia of infancy, there is increased tissue oxygenation at birth, increased tissue oxygenation at birth, downregulation of the erythropoietin. Clinical feature is asymptomatic term infant, age 2 to 3 months. Asymptomatic term infant, age 2 to 3 months. There may be normocytic anemia, hemoglobin 9 to 11, and low to normal reticulocyte count. Reassurance: anemia resolves with increased erythropoietin. Anemia resolves with increased erythropoietin drive after age 3 months. Preterm infant has lower nadir at a younger age. Anemia of prematurity. Although absolute value of the reticulocyte count may be normal, a compensatory reticulocytosis in response to anemia is absent. After age 2 to 3 months, the erythropoietin drive returns and hemoglobin levels rise. After age 2 to 3 months, the erythropoietin drive returns and hemoglobin levels rise. Iron deficiency, decreased dietary iron, low iron absorption can cause microcytic anemia. Low MCV. The diagnosis is rare before age 4 to 6 months because iron stored in young infant are derived from mother in the uterus. So iron deficiency anemia before 4 to 6 months is rare because young infants are derived from um, the mother in utero. Okay, mean hemoglobin in term infant. Look at the mean hemoglobin. The term infant, these near about 18 or 20 hemoglobin is getting down and up to 10 and 11 milligram per deciliter at 2.5 months. But in case of preterm, their hemoglobin starts near about 15 or 16, so it is again getting down. It is below 10, near about 8 on the 2 months, and they become equal at 6 to 7 months. So hemoglobin nadir can fall as low as 7 gram per deciliter in preterm and 9 gram per deciliter in term infant. So this is all about the pediatric part of the hematology. In here there are some simple topics like physiologic anemia of infancy, where there is normocytic normochromic anemia, and asymptomatic at term infant, and it happens due to increased tissue oxygenation. And there is anemia of prematurity, and most important is neonatal polycythemia. Okay, hope you enjoyed. It's a very simple video. Hope you enjoyed. If you like my video, give comment and share, and mainly answer the question of this video. Like, look at this video again. Can you tell me the diagnosis?